Welcome to Uber School's comprehensive guide on cell injury and adaptation for the USMLE Step 1 pathology exam. I'm your host, Pete, and with me today is my esteemed colleague.
Hey there, folks. It's Gary, but you can call me Crash. Poot and I are here to make sure every single one of you aces this section of the exam. No pressure, right?
That's right, Crash. We're diving deep into the microscopic world of cellular pathology. By the end of this Uber School production, you'll be experts in cellular responses to stress, types of cell injury, and the fascinating realm of cellular adaptations.
All right, Pete, let's kick things off with cellular responses to stress. It's like a cellular boot camp out there.
You got it, Crashington. Cells are constantly bombarded with various stressors, and their ability to respond determines their fate. We'll be exploring 4 key stressors: oxidative stress, hypoxia, temperature extremes, and radiation.
Hold up, Petey. Before we dive in, let's hit our future doctors with a quick question to get their neurons firing. Here's a USMLE-style question for ya.
Bring it on, Crash.
A 65-year-old man presents with chest pain and shortness of breath. An ECG shows street segment elevation, and blood tests reveal elevated cardiac enzymes. Which of the following best describes the cellular response to the underlying pathology?
Ooh, that's a good one. Let's give our listeners a moment to think about it. We'll come back to the answer after we discuss oxidative stress. Speaking of which, Crash, what can you tell us about this cellular stressor?
Well, Pete, oxidative stress is like a bar fight in the cell. It occurs when there's an imbalance between free radical production and antioxidant defenses. Free radicals, such as reactive oxygen species, ROS, are like the rowdy troublemakers, damaging cellular components through lipid peroxidation, protein oxidation, and DNA damage.
Nice analogy, Crash. And I suppose antioxidants like glutathione, vitamin C, and vitamin E are the bouncers trying to keep the peace?
Exactly. These antioxidants play crucial roles in mitigating the damage caused by free radicals. It's like a constant tug-of-war between the troublemakers and the peacekeepers.
Now let's talk about hypoxia. This is when cells don't get enough oxygen, which can happen due to various causes such as ischemia, anemia, or high altitude. At the cellular level, hypoxia triggers a fascinating response involving the HIF1 alpha pathway.
HIF1 alpha? Sounds like a secret agent, Pete.
Close. Crash. HIF1 alpha stands for hypoxia-inducible factor 1 alpha. It's a transcription factor that's activated when oxygen levels are low. Think of it as the cell's emergency response system.
So what does this secret agent, transcription factor do?
Great question. HIF1 alpha upregulates genes involved in angiogenesis, erythropoiesis, and glycolysis. In simpler terms, it helps cells adapt to low oxygen conditions by promoting the formation of new blood vessels, increasing red blood cell production, and shifting metabolism to anaerobic glycolysis.
Fascinating stuff, Pete. It's like the cell's version of a backup generator kicking in when the power goes out.
That's a great way to think about it, Crash. Now, before we move on to temperature extremes, let's revisit that USMLE question you posed earlier. Any thoughts on the answer?
Absolutely. The correct answer would be hypoxia-induced cellular adaptation. The patient's symptoms and test results suggest a myocardial infarction, where heart cells are deprived of oxygen. This triggers the HIF1 alpha pathway we just discussed, helping cells adapt to the low oxygen environment.
Excellent explanation, Crash. Now, let's move on to how cells respond to temperature extremes. This is particularly relevant when we think about conditions like heat stroke or frostbite.
Right you are, Pete. When it comes to heat stress, cells have a pretty cool trick up their sleeve, no pun intended. They start producing what we call heat shock proteins, or HSPs.
And what do these HSPs do, Crash?
Well, Pete, these HSPs act like tiny molecular chaperones. They help prevent other proteins from denaturing or misfolding due to the heat. It's like they're giving other proteins a protective hug to keep them in shape.
That's a great way to put it, Crash. On the flip side, what happens with cold injury?
Cold injury is a whole different ballgame, Pete. Take frostbite, for example. The extreme cold causes ice crystals to form inside and outside the cells. This leads to cellular dehydration and membrane damage. It's like the cell is being stabbed by tiny icicles from all directions.
Ouch, that sounds painful. Now let's move on to our final stressor, radiation injury. This is a topic that's particularly relevant in our modern world with increased exposure to various forms of radiation.
You're right, Pete. And it's not just about nuclear accidents or X-rays. We're exposed to low levels of radiation all the time, from the sun, our electronic devices, and even naturally occurring radioactive materials in the environment.
Exactly, Crash. Now, radiation can cause both direct and indirect cellular damage. Can you elaborate on that?
Sure thing, Pete. Direct damage occurs when radiation directly ionizes DNA molecules. It's like a tiny missile hitting the DNA and causing breaks in the strands. Indirect damage, on the other hand, is mediated by free radicals generated from water radiolysis. These free radicals then go on to damage cellular components.
Great explanation, Crash. And how do cells respond to this radiation damage?
Well, cells are pretty resilient, Pete. They activate various DNA repair mechanisms to deal with the damage. These include base excision repair for single-strand breaks and more complex mechanisms like non-homologous end joining for double-strand breaks.
Fascinating stuff, Crash. Now, before we move on to types of cell injury, let's hit our listeners with another USMLE-style question to keep them on their toes.
I'm all A's, Pete. Fire away.
A researcher is studying the effects of different stressors on cellular function. She observes that exposure to a particular agent causes an increase in the production of heat shock proteins, HSPs. Which of the following stressors is the researcher most likely using in her experiment?
Ooh, that's a good one, Pete. Let's give our listeners a moment to think about it. We'll come back to this after we discuss types of cell injury.
Sounds good, Crash. Now let's dive into the different types of cell injury. We'll be examining reversible injury, irreversible injury, ischemic/hypoxic injury, and chemical injury.
Hold up, Pete. Before we get into the nitty-gritty, let me tell you about this guy the first once knew named Marcus Cooper. Now, Marcus was a real whiz when it came to cell biology. Legend has it, he once memorized the entire cellular injury cascade while bungee jumping off the Golden Gate Bridge.
Crash, I'm pretty sure that's physically impossible.
Maybe for mere mortals, Pete, but Marcus Cooper was something else. Anyway, let's start with reversible cell injury. What can you tell us about that?
Well, Crash, reversible cell injury is characterized by cellular swelling, fatty change, and plasma membrane blebs. These changes are potentially reversible if the injurious stimulus is removed in time. Key features include dilated endoplasmic reticulum and mitochondrial swelling.
So it's like the cell is teetering on the edge but hasn't fallen off yet?
That's a good way to think about it, Crash. Now, what about irreversible cell injury?
That's when the cell has gone past the point of no return. Irreversible cell injury involves more severe changes, including nuclear pygnosis or karyorrhexis, extensive mitochondrial damage, and lysosomal rupture. These changes ultimately lead to cell death through necrosis or apoptosis.
Excellent explanation, Crash. Now, let's talk about ischemic or hypoxic injury. This is particularly relevant when we think about conditions like heart attacks or strokes.
Right, you are, Pete. Ischemic or hypoxic injury results from oxygen deprivation. It leads to ATP depletion, failure of ion pumps, and subsequent calcium overload. It's like the cell's power grid is shutting down and all hell breaks loose as a result.
That's a vivid description, Crash. And this cascade of events can quickly progress from reversible to irreversible injury if not addressed promptly, right?
Exactly, Pete. Time is of the essence in these situations. Now, what about chemical injury?
Chemical injury, also known as toxic injury, can occur through various mechanisms. These include direct cell membrane damage, enzyme inhibition, and free radical formation. Some classic examples include carbon tetrachloride-induced liver damage and acetaminophen toxicity.
Speaking of acetaminophen toxicity, that reminds me of another USMLE-style question. Want to hear it, Pete?
Absolutely, Crash. Let's hear it.
A 25-year-old woman is brought to the emergency department after ingesting a large quantity of acetaminophen in a suicide attempt. Which of the following best describes the mechanism of hepatotoxicity in acetaminophen overdose?
That's an important question, Crash. Let's give our listeners a moment to think about it. We'll come back to the answer after we discuss the distinction between reversible and irreversible cell damage.
Sounds good, Pete. So what's the key difference between reversible and irreversible cell damage?
Great question, Crash. The main distinction lies in the extent and severity of the cellular changes. In reversible injury, cells exhibit swelling and fatty change. These changes can be reversed if the injurious stimulus is removed in time.
And irreversible injury?
Irreversible injury is marked by more severe changes, including extreme swelling, vacuolization, and nuclear changes like pycnosis or karyarexis. Once these changes occur, the cell is destined to die, even if the injurious stimulus is removed.
Gotcha. So it's like the difference between a fender bender and a total car wreck.
That's a good analogy, Crash. Now let's talk about the biochemical changes that occur in these types of injury.
Lay it on me, Pete.
Well, ATP levels drop in both types of injury, but they're severely depleted in irreversible damage. pH changes and enzyme release, particularly lysosomal enzymes, are more pronounced in irreversible injury. It's like the cell's internal factory is shutting down and spilling its contents everywhere.
Interesting. And I've heard about something called the point of no return in cell injury. What's that all about?
The point of no return in cell injury involves severe mitochondrial damage, extensive plasma membrane damage, and nuclear dissolution. Once these events occur, cell death is inevitable. It's like the cell has crossed a threshold from which it can't recover.
Sounds pretty final, but here's something that always confused me, Pete. I've heard about reperfusion injury. Isn't bringing blood flow back to an ischemic area supposed to be a good thing?
That's a great point, Crash. Paradoxically, restoration of blood flow to ischemic tissues can cause additional damage through reperfusion injury. This involves the generation of free radicals and inflammatory mediators upon reoxygenation.
So it's like throwing gasoline on a smoldering fire.
That's a vivid analogy, Crash. Now, let's circle back to that USMLE question about acetaminophen toxicity. Any thoughts on the mechanism?
Ah, yes, the acetaminophen question. The correct answer would be formation of toxic metabolites by cytochrome P450 enzymes. In an overdose, the normal detoxification pathways get overwhelmed and more acetaminophen gets shunted to the cytochrome P450 pathway. This produces a toxic metabolite called NAPQI, which depletes glutathione and causes oxidative stress and cell death in the river.
Excellent explanation, Crash. Now let's move on to mechanisms of cell death. We'll be covering apoptosis, necrosis, autophagy, and pyroptosis.
Sounds like a real party, Pete. Let's start with apoptosis. What can you tell us about this programmed cell death?
Apoptosis is a highly regulated form of cell death. It involves the activation of caspases through either the intrinsic, mitochondrial, or extrinsic death receptor pathways. Morphologically, it's characterized by cell shrinkage, chromatin condensation, and formation of apoptotic bodies.
So it's like the cell is neatly packing itself away.
That's a good way to think about it, Crash. Now, how about necrosis?
Necrosis is the messy cousin of apoptosis. It's characterized by cell swelling, plasma membrane rupture, and inflammation. It's like the cell explodes, spilling its contents everywhere and causing a ruckus in the neighborhood.
Nice description, Crash. And there are different types of necrosis, right?
That's right, Pete. We've got coagulative necrosis, which is the most common type and occurs in most organs. Then there's liquefactive necrosis, which is seen in the brain. And let's not forget caseous necrosis, which is characteristic of tuberculosis.
Excellent summary, Crash. Now let's talk about autophagy. This is a fascinating process that can promote cell survival or lead to cell death.
Autophagy, huh? Sounds like something out of a sci-fi movie.
It does sound futuristic, doesn't it? Autophagy is actually a cellular recycling process. It involves the formation of autophagosomes, which are like little bubbles that engulf cellular components. These autophagosomes then fuse with lysosomes to degrade their contents.
So it's like the cell is eating itself?
In a way, yes. It's a survival mechanism that allows cells to recycle damaged components and generate energy during times of stress. But excessive autophagy can also lead to cell death.
Fascinating stuff, Pete. Now, what about this pyroptosis? Sounds like something that would happen to a dragon.
Not quite, Crash, but it is an inflammatory form of programmed cell death. Pyroptosis is characterized by caspase-1 activation, release of pro-inflammatory cytokines, and plasma membrane pore formation.
So it's like the cell is going out with a bang and calling all its inflammatory friends to the party?
That's a colorful but accurate description, Crash. Now, before we move on to pathological calcification, let's hit our listeners with another USMLE style question.
Bring it on, Pete.
A pathologist is examining a tissue sample from a patient with chronic inflammation. She observes cells with condensed chromatin, fragmented nuclei, and intact cell membranes. These cells are most likely undergoing which of the following processes?
Ooh, that's a good one, Pete. Let's give our listeners a moment to think about it. We'll come back to the answer after we discuss pathological calcification.
Sounds good, Crash. Now, let's talk about pathological calcification. This involves the abnormal deposition of calcium salts in tissues, and it can be classified into two main types, dystrophic and metastatic calcification.
All right, Pete, let's start with dystrophic calcification. What's the deal with that?
Dystrophic calcification occurs in damaged or necrotic tissues with normal serum calcium levels. It's like calcium decides to set up shop in areas that are already in trouble. Common examples include calcification in atherosclerotic plaques and tuberculous lesions.
So it's like adding insult to injury.
That's one way to look at it, Crash. Now, what about metastatic calcification?
Metastatic calcification is a whole different ballgame. It results from hypercalcemia and can occur in normal tissues. It's like calcium is going on a road trip and depositing itself wherever it pleases. Causes include hyperparathyroidism, malignancy-associated hypercalcemia, and vitamin D toxicity.
Great explanation, Crash. Can you give an example of metastatic calcification?
Sure thing, Pete. A classic example is nephrocalcinosis, where calcium deposits form in the kidneys. It's like the kidneys are turning into stone, and not in a cool superhero way.
Nice analogy, Crash. Now let's talk about the cellular mechanisms behind calcification.
Hit me with it, Pete.
At the cellular level, calcification involves matrix vesicles and calcium-binding proteins like osteopontin. These facilitate the nucleation and growth of calcium crystals in the extracellular space. It's like they're providing a scaffold for calcium to build upon.
Fascinating stuff, Pete. Now, before we wrap up, shall we circle back to that USMLE question about cell death?
Absolutely, Crash. What's your take on it?
Well, based on the description of condensed chromatin, fragmented nuclei, and intact cell membranes, the cells are most likely undergoing apoptosis. Remember, apoptosis is that neat programmed cell death we talked about earlier.
Excellent answer, Crash. Now let's wrap up with a quick overview of cellular adaptations. These are reversible changes in cell structure and function in response to stress.
All right, Pete, what kinds of adaptations are we talking about?
Well, we have hypertrophy, which involves an increase in cell size. This is seen in cardiac and skeletal muscle. Then there's hyperplasia, which is an increase in cell number. Examples include endometrial hyperplasia and liver regeneration.
So hypertrophy is like the cell hitting the gym, and hyperplasia is like the cell cloning itself.
That's a fun way to think about it, Crash. Now, we also have atrophy, which is a decrease in cell size and function. This can be caused by disuse, denervation, or ischemia. It's like the cell is wasting away.
Got it. And what about metaplasia? Sounds like something out of a sci-fi movie.
Metaplasia is actually the replacement of one cell type by another. A classic example is intestinal metaplasia in Barrett's esophagus. It's like the cells are switching identities to better handle stress.
Cellular shapeshifters, huh? Cool. Any other adaptations we should know about?
Yes, there's one more important one, dysplasia. This represents disordered growth and is a precursor to neoplasia. It's graded as mild, moderate, or severe, with cervical intraepithelial neoplasia being a classic example.
Sounds like dysplasia is when cells start to go rogue. Not good news, I imagine.
You're right, Crash. It's definitely something that needs close monitoring. Well, that brings us to the end of our comprehensive overview of cell injury and adaptation.
Wow, what a journey through the cellular world, Pete. I feel like we've been on a microscopic adventure.
It certainly has been, Crash. Remember, understanding these fundamental concepts is crucial for grasping more complex pathological processes. They're the building blocks of pathology.
Absolutely, Pete. And to all our listeners out there, don't forget, every single one of you is going to ace this section of the exam. We believe in you.
That's right, Crash. And remember, this has been an Uber School production. We're here to help you succeed. Any final words, Crash?
Just one thing, Pete. To all our future doctors out there, stay curious, keep studying, and never stop learning. You've got this.
Couldn't have said it better myself, Crash. Until next time, this is Pete.
And Crash.
Signing off from Uber School. Good luck with your USMLE Step 1 preparation.